It's my big pleasure today to be back with you all again for a roundup of important abstracts presented at ASCO 2022. This was a very nostalgic and important meeting, post-pandemic, first in-person meeting, and there was huge enthusiasm. And ASCO didn't disappoint. Meeting friends was an important part of this event, but let's get to the trials that makes ASCO what it is. Okay, first I would like to start with the GI trials that were presented at this ASCO. Let's start with the paradigm study, which was presented at the plenary session from Japanese group, and I might have a conflict of interest here. The senior author is my mentor from Japan, Dr. Muro. So anyways, paradigm trial was conducted to test the efficacy of panitumumab, which is an EGFR monoclonal antibody, versus bevacizumab, which is a VEGF inhibitor in left-sided colon cancer. When this trial started, there was no evidence for difference in efficacy of treatment or even prognosis based on right versus left-sided colon cancer. But as the trial was starting, there was evidence coming up showing right and left-sided colon cancers behave differently, so we need to treat them differently. Based on that information, they changed the primary endpoint to overall survival in left-sided colon cancer only, and then if that is positive, then they would look after the entire colon cancer. So we had seen data from CALGB 80405 trial in the past, but that was a retrospective look at the data before knowing about the sidedness effect. And that trial actually showed that bevacizumab and panitumumab or cetuximab might be similar. However, if it is left-sided, then EGFR antibody is effective, whereas if it is right-sided, then EGFR antibody might not have any beneficial effect. That is something that we knew from the CALGB trial. But in this paradigm, the Japanese trial, for left-sided colon cancer only, they were trying to look at panitumumab plus FOLFOX versus bevacizumab plus FOLFOX. And the primary endpoint, as I mentioned, is overall survival in left-sided colon cancer. And they found that actually panitumumab improves median overall survival by almost 4 months, 38 months versus 34 months, with a hazard ratio of 0.82. The hazard ratio does not sound too impressive, but these drugs have always provided incremental benefit to begin with. These are not big game changers, but the incremental benefit is there, and there is an absolute difference of 4 months of survival here, and which is statistically significant. But there are a couple of things that are very intriguing for me in this trial. One is, why would there be a crossover of the curves at 28-month point, which is intriguing. If we had taken a look at the data before that time, probably we would have concluded just opposite. And the other thing is that PFS actually is negative here. There is no difference in progression-free survival. And this is not an immunotherapy, so I would not expect why PFS would be negative, but OS would go on to be positive. And this also shows that PFS is actually not a good surrogate endpoint, but for the opposite reason in this case, because usually you see PFS positive, OS negative. Here PFS is negative, but OS is positive. And fortunately, the primary endpoint is OS, so we can trust the OS data. But this goes on to show why we cannot rely on surrogate endpoints for both the reasons. It can underestimate, it can also overestimate the findings. So there was some discussion going on social media about the role of surrogate endpoint, but I think what we can confidently say is, rather than trying to guess what happens to the surrogate endpoints and trying to find the surrogacy validation for each treatment type and subtype of tumor separately, it's much better to just go and test for OS so that we'll have an answer rather than having to guess all the time, oh, is this validated, is this not validated. After they found that the overall survival was significant in the left-sided colon cancer, they also tested for the entire population, and they found that it was positive for the whole colon cancer as well. But however, when they looked at right-sided colon cancer only, which was an exploratory analysis, we saw what we expect. That is, probably panitumumab is harmful, or bevacizumab is more beneficial for right-sided colon cancer. So yes, it is practice affirming, like we are already doing that. For left-sided colon cancer, you could have the option of EGFR antibody as well as bevacizumab, but based on this data, I guess it is more appropriate to go with EGFR antibody upfront. But the practice of treating colon cancer has changed in recent years. We have MSI high tumors benefiting from immunotherapy. This trial tested only FOLFOX as the chemotherapy backbone. They have not tested this with FOLFIRI. So those questions are still remaining. But however, it was a good trial to see. It is practice affirming trial. But those questions about why the curves crossovered at 28 months point and why PFS was negative, those are something to think about in the future. Okay. So the second study in colorectal cancer is the dynamic study that I want to talk about. This was published in New England Journal of Medicine as well, simultaneously with the ASCO. The adjuvant treatment for stage 2 colon cancer is not very straightforward. We separate our patients into high risk and low risk, and high risk patients do get adjuvant chemo, but low risk patients we do not give adjuvant chemo. But this study was interesting because they were trying to check whether using circulating tumor DNA can guide in our management, and basically whether we can avoid chemotherapy for patients who do not need it, which is a very worthwhile goal to achieve. What they did in this trial is they randomized patients 2:1 into circulating tumor DNA guided management versus standard management. I already described what our standard management looks like, but in the circulating tumor DNA arm, what they did was for stage 2 colon cancer patients, they measured circulating tumor DNA at 2 different time points, and if it is positive, then those patients got chemo, and if it is negative, those patients did not get chemo. Their primary endpoint was to look at what % of patients can avoid chemo, and they found that circulating tumor DNA guided treatment arm, 15% of the patients got chemo, and in the standard management arm, 28% of the patients got chemo. So there was like 13% fewer patients who got chemo with this strategy. So there is definitely some benefit there in terms of 13% of the patients can avoid chemotherapy. But avoiding chemotherapy alone cannot be the goal. If you avoid chemotherapy but go on to relapse, then that does not make sense. So they looked at 2-year recurrence-free survival. And in terms of 2-year recurrence-free survival, they were aiming for non-inferiority. And that non-inferiority was proven because 2-year recurrence-free survival was 93.5% versus 92.4%, 1.1% difference. So they conclude that we can use circulating tumor DNA as a strategy to allow lesser patients to get adjuvant chemo. So we are sparing more patients from unnecessary toxicity of chemo without compromising efficacy. But that's what the study is. I have a couple of comments on this study. One is that this was not a very neat way to look into the question that affects us because we already avoid chemo for low-risk patients. So a better strategy would have been to avoid chemo for low-risk patients because we are avoiding it anyway, and then only among the high-risk patients, they should have done circulating tumor DNA test, and positive got chemo, negative did not get chemo, and what happened? Because in this study, as such, there are 60% patients who are low-risk. They were not going to get chemo anyway. That is one important caveat. And the other thing is, if someone like a trainee is reading this paper, then they should not be misguided because this is a part of the study. That's why they did an intense surveillance, which is not usual for normal practice. By that I mean they did CEA test every 3 months. They were doing CT scan imaging every 6 months. That is quite intense surveillance follow-up. We don't do that in routine practice. Having said that, my take-home message or take clinic message from this trial would be that we would need more studies of circulating tumor DNA for de-escalation of treatment. It is an important goal to work towards. But for low-risk patients, I don't think we need circulating tumor DNA unless proven that even low-risk patients with positive circulating tumor DNA are at a high risk of relapse, which we have not proven yet. But for high-risk patients, and I think those trials are ongoing, so we will have an answer in near future. But our goal is whether high-risk patients they need, or whether treating them based on circulating tumor DNA makes a difference. And the other question is the duration of treatment. I think in this study, one other caveat was that for patients who had circulating tumor DNA positive, they received oxaliplatin-based chemo, most of them. But the patients who were randomized to the standard management arm, they mostly, I think 90% of them, they received 5-FU alone. So that is an important bias there. Standard treatment, most of the patients are getting a single agent chemo, but in the circulating tumor DNA arm, if it is positive, then people are getting 5-FU plus oxaliplatin, a doublet. So that's something to keep in mind. Moving on with GI cancers, there was a very interesting study from rectal cancer, neoadjuvant treatment with PD-1 antibody dostarlimab. So this is a new immunotherapy. And actually the study was designed such that they wanted to test whether giving immunotherapy as a neoadjuvant strategy can avoid surgery and chemoradiation, because surgery and neoadjuvant chemoradiation has a big quality of life toll on the patient. So can we avoid it? That's a very important question to ask. So the study was designed that they would give this new immunotherapy as a neoadjuvant treatment, and if patients achieve complete response, then they would just wait and watch. If patients did not achieve complete response, then they would move on to get chemoradiation and surgery, and then they would look at the pathological complete response rate. However, interestingly, they recruited 16 patients, of which 12 patients have 6 months of follow-up, and that's the data that they are presenting now. All of them had complete response, so the other arm was not even necessary. None of them had less than complete clinical response. That's why it created big buzz, like it was 100% complete clinical response rate. And this is something actually quite remarkable. However, again, there are some caveats to that. It's a very small sample size, and the duration of follow-up is, the median duration of follow-up is, I guess, 12 months, ranging from 6 to 25 months. There are only 4 patients who are responding more than 1 year after treatment. Yes, this is really remarkable. This is not something that you see with chemoradiation all the time. However, the caveat is that can these patients avoid surgery? Because surgery is curative treatment, and these patients, after they undergo surgery, many of these patients will be cancer-free for several years. Some of them will be cured. But with this strategy, it's still too premature to say that we'll have similar outcomes, long-term cure by using just immunotherapy. And I think it is, like, as a patient, I think it is risky to think that, okay, I'll get immunotherapy and I'll not undergo surgery. Because if you undergo surgery, you can be confident that your chances of cure are pretty high. But with this, you never know. We don't have long-term data. Relapse rates could be high. The longest follow-up patient is 25 months. We need like 60 months data. We need 5-year DFS rates. But this is quite promising. That is why, I guess, with just 12 patient sample, it got into New England Journal as well. I was quite surprised to see it in New England Journal with 12 patients. But having said that, it's not a random 12 patients. It's according to the statistical plan. So I don't have any complaints about that. I just want to caution patients and physicians that outside of the setting of a trial, probably just getting immunotherapy and not undergoing surgery might be a risky strategy. Continuing with our GI group, I want to talk about the sequence trial. Sequence trial was very interesting. In pancreatic cancer, we usually give gem-Abraxane as the first-line treatment or FOLFIRINOX, depending on the performance status of the patients. For very fit patients, we give FOLFIRINOX because they have not been compared head-to-head, but it is an impression that FOLFIRINOX probably gives longer survival. And for other patients, we give gem-Abraxane. But this trial tested whether giving gem-Abraxane followed by FOLFOX and compared that with gem-Abraxane and they tried to see whether there is a survival advantage. I think it makes sense in a way, because not all pancreatic cancer patients maintain good performance status to get 2 lines of treatment. Some or majority of them, they get only 1 line of treatment and then they decompensate. So I think this was a nice strategy to test whether we could give all possible good drugs when the patient has good performance status upfront. So they gave gem-Abraxane routinely, but after gem-Abraxane was complete, at a 4-week time point, they gave FOLFOX. So this was a 6 weeks regimen, and they compared it with standard gem-Abraxane regimen, and they found an OS difference, 13.2 months versus 9.7 months. It's very difficult to make cross-trial comparisons and to see how it compares with FOLFIRINOX or gem-Abraxane with FOLFIRINOX, but these survival results are quite comparable with what we saw in the trial of FOLFIRINOX. So this could be a very good strategy. I want to read the full paper about this. I have only seen the abstract, but once I see the full paper, I think I might be convinced that this might be a good strategy. And there was, in pancreatic cancer, one more trial of nimotuzumab, which is an EGFR antibody. And this trial came from China, and they compared this EGFR antibody called nimotuzumab plus gemcitabine versus gemcitabine in KRAS pancreatic cancer, and they found a survival difference of 10.9 versus 8.5 months. However, the problem here is that the comparator arm is gemcitabine alone. If the patient is fit enough, I think we would prefer to give gem-Abraxane or FOLFIRINOX, not gemcitabine alone. However, in the local setting, I think Abraxane is also an expensive drug, and this is a locally developed drug in China, and it has shown clear survival advantage here against gemcitabine. So I think it will be an effective and a good treatment option to have, at least for the local population. In the same vein, there was one more trial from China, but this was in prostate cancer, hormone-sensitive prostate cancer, a new androgen receptor inhibitor. I think it does not even have a name yet, but again, compared to other expensive new generation androgen receptor inhibitors that we have, I think this will be again a very good option. There have been a number of newer Me Too drugs that are coming out of China, and I touched on that and the regulatory and scientific and ethical issues of these trials in my talk as well. So I won't comment much about it, but these are good options to have, and it's good to see several of these newer drugs that are being locally developed, and that will probably have a price competition. So this ASCO was a very important event for breast cancer community. There were, I think, especially 3 important trials that were presented. So the first trial is Destiny Breast 04. It was presented at the plenary session, received a standing ovation, a huge cheer from the crowd. This is a trial of trastuzumab deruxtecan, an antibody drug conjugate against treatment of physician choice. The reason I think this trial got so much of applause and is exciting is for a couple of reasons. One, obviously, I'll talk about the magnitude of clinical benefit and the results, but the second is it changed the way we think about breast cancer categories. We used to say there is HER2 positive cancer and HER2 negative cancer, and we used to define it based on IHC and FIS. IHC of 1+, we say this is HER2 negative. IHC of 0, 1+, negative. 2+, we would say equivocal, and do a FIS, and if FIS is positive, we would say this is positive. If FIS is negative, we would say this is negative. And 3+ and more, we would say this is positive. But in this trial, they defined a category called HER2 low. So not just positive and negative, but HER2 low. So how do we define that? If it is IHC 0, then it's clearly negative, but 1+ is low, 2+ is also low. 2+ and FIS negative is also low. So this category of tumors is what we're studying here. and we have never studied this category of tumors formally as a clinical trial before, and we did not have positive results before. So that's why from biology point of view, it is exciting. And to talk about the trial design, as I said, this was a trial of trastuzumab deruxtecan versus treatment of physician choice for patients with hormone receptor positive breast cancer. And there is these patients had received previous endocrine therapy, and these patients had also received previous chemotherapy. This is for patients who had received at least 1 to 2 lines of chemotherapy in the past and must have received endocrine therapy. The treatment of physician choice arm included capecitabine, eribulin, gemcitabine, paclitaxel, and Abraxane. There were 5 different choices that the physician could use. And first, let's go to the results. They found that the median progression-free survival increased by almost 5 months, 4.7 months, and the hazard ratio was almost 0.51, in the range of 0.5. So almost 50% reduction in the hazard of progression-free survival. Overall survival increased by 6.5 months, and this had a hazard ratio of 0.6, in the range of 0.6. So that's what got all of us excited, and that's why it received applause, because increasing overall survival by more than 6 months after the patient has already received a number of lines of treatment is something that we don't see every day. However, again, here are a couple of things that we need to consider that I think we have not been talking about because we got super excited about the data. And again, this is not to say that this trial is not practice changing, but a couple of things that we need to consider in interpretation of the results is, one, we do not know which chemo the patients have received previously. We have been told that the patient have received at least 1 line of chemo, but how many of them received just 1 chemo, and how many of them received more than 1 line of chemo, and what those chemo were. I just don't want to see that a patient who had progressed on paclitaxel is again getting paclitaxel in the trial, or the patient who has progressed on capecitabine is getting capecitabine. So what were the chemotherapies the patient had previously received before the trial? That is the data that I want to see, and I had some time to look into it in the publication. I didn't have too much time to go into detail, but in my brief look of the supplementary appendix, I could not find that information. And the other thing to consider here is that the enrollment from North America is pretty low. It is mostly enrolled in Asia and Europe. So we need to know what the post-protocol treatments were. Did patients get the same balanced treatment post-trial? If there is a huge disbalance in that, we need to consider that into the magnitude of benefit. Is that biasing the magnitude of benefit? The other thing is we need to also consider the side effects when we make a decision, because this drug is not easy. There was 12% incidence of interstitial lung disease. Let's forget about other side effects. Interstitial lung disease alone is a big deal with this drug. There were 12% of the patients who got this, and 0.8% of the patients actually had fatal interstitial lung disease. So when we are using it in a huge, because the eligible patient population is going to be huge, 0.8% will translate to a huge number of absolute lives. That is something we need to consider. So how are we going to be vigilant about it? Because this is in the trial setting. If in a trial setting 0.8% of the patients are dying from interstitial lung disease alone, then that is something that scares me. And to connect with that, the same drug was also tested in biliary tract cancer called the HARB trial. This was from the Japanese group, because it's the same drug. I wanted to connect it here. And again, and they showed 36% response rate in this trial. It was a phase 2 trial. It is worthy of being investigated in a phase 3, but the interstitial lung disease rate in this trial was 25%, and 6% of the patients had fatal interstitial lung disease. 6% is pretty big. we have some drugs that are approved on the basis of 6% response rate. We're talking about 6% fatal adverse event from a drug. So yeah, this should be really well thought out before we start treating our patients, and we need to monitor any respiratory symptoms. We need to do a long focused CT scans, and we need to really keep an eye on our patient's respiratory function. But going back to the Destiny Breast 4, those are a couple of points that we need to consider about pre-trial chemotherapy, post-trial treatment, and interestingly, CDK4/6 inhibitors was received by 65% of the patients. It was not 100%, but they did do a subgroup analysis, and they showed benefit across the subgroups. But I look forward to reading the publication in further detail. But this was this hazard ratio and magnitude of benefit was quite substantial, and that's why it got all of us excited. But let's not forget some other parts as well. But I do believe that it is a practice-changing trial. But I want to see the pre-treatment and post-treatment, pre-trial and post-trial treatments that the patients got. The next breast cancer trial that was presented was TROPiCS-02 trial of sacituzumab govitecan versus, again, treatment of physician choice for hormone receptor positive, HER2 negative breast cancer. They showed that median PFS increased by 1.5 months, 4 versus 5.5 months. OS was not yet mature. Again, for this hormone receptor positive, HER2 negative patients who have already progressed on endocrine therapy and chemotherapy. So this was more like last line treatment. And this drug does have significant toxicities that we cannot ignore. But people were saying that this is a practice-changing trial, this is a game-changing trial. I do not think that it is. We do not have OS yet in almost last line of treatment. So I would somewhat understand if this was first line of treatment, that you would say, oh, it would take 5 years, 6 years for hormone receptor positive patients to find OS. There are so many post-trial treatments which will confound the result. But if you cannot improve OS in the last line, then it's like I'm not convinced. So when the OS becomes mature, it might show positive benefit. Then I'll say okay. But the magnitude, even for PFS, it's just 1.5 months. It's just delaying your scan by 1.5 months. And if OS does not pan out, this is not worthwhile. The funny thing is, let's compare with Destiny. Destiny improved OS, right? Destiny significantly improved OS. So when Destiny improved OS by like 6 months, more than 6 months, we are like, wow, that's great. And here, if it did not improve OS, this sacituzumab govitecan, we should be saying like, oh, it did not improve OS, so this is not practice changing. How difficult it is. If in Destiny Breast 04, it is a good drug, it did improve OS. So if your drug is good, OS will improve. If you have to come up with different excuses in last line of treatment for why OS does not improve, then that's not a good drug. And the third breast cancer trial was called the Lumina trial. I do not have data about it today. It will be presented in a couple of days, and I'll talk about it at that time. Now moving on to lung cancer, there was one long MAP trial that was testing ramucirumab plus chemotherapy versus ramucirumab plus pembrolizumab among patients who had already failed on immunotherapy. That was interesting, but we do not have the publication, so there is only abstract to look at. However, it is interesting to think what the role of ramucirumab here might be. Ramucirumab is a marginal drug, as we know, from its REVEL trial, docetaxel versus docetaxel plus ramucirumab. And in this case, ramucirumab is there in both the arms, in interventional arm as well as the control arm. It's pembro plus ramucirumab versus chemo plus ramucirumab. And of course, there are biological theories as to why immunotherapy plus angiogenesis inhibitor might work together, but I really doubt the efficacy of ramucirumab here and what added benefit it might provide. So basically, is it similar to pembro after, like immunotherapy after progression on immunotherapy? So we really need to look at the publication, because we do not know for how long duration the patients were responding in the previous immunotherapy, what the previous immunotherapy was. Are these patients progressing on nivo, atezo, or pembro itself, and are they again getting pembro? It was intriguing, but it's definitely not practice changing in my opinion. And on top of it, it's a phase 2 trial, and we know that phase 2 trials mislead us a number of times. It's not a phase 3. And the other lung cancer trial was the trial of adagrasib, which is a KRAS inhibitor for lung cancer patients with KRAS G12C mutation. This was again a phase 2 single arm trial, response rate of 43%, progression-free survival median 6.5 months. It's interesting, but I would not get too excited about it, because in phase 2 single arm trials, the patients are highly selected. You do not select your everyday patient there. You select very fit patients. And previous studies, retrospective studies from the precision medicine cohorts have also looked at patients with this mutation in lung cancer, and even those patients have a PFS of 4.5 months, 5 months on average, and this is a PFS of 6.5 months. So without a comparator, without a control arm, it's really difficult to say anything. I want to talk about a couple of GU cancer trials. Only a couple have been presented by now. So in the prostate cancer, the therapy trial, OS data, those are very interesting to me. This is a trial of lutetium PSMA versus cabazitaxel done by the ENZAMET group in Australia and New Zealand. And actually, I like this trial because previously Vision trial was published last year, I think, for the same drug, lutetium PSMA, but they used a control arm that I believe is an inferior control arm. The appropriate control arm would have been cabazitaxel, but that trial did not use cabazitaxel as the control arm. And there were several arguments given as to why that cannot be done, but the therapy trial did use cabazitaxel as a control arm, so it can be done. And the other thing is, this is an academia-sponsored trial, so they used the right control arm. That's why we need to fund more academia-led trials and not just rely on the industry-sponsored trials. And the results here, OS was not improved. Obviously, Vision trial showed that OS improved because they used a bad control. Here, when you use the standard control, the OS was not improved. Does lutetium have a place? It may, because they showed that like the OS numbers are similar, but obviously we had expected to see if OS would improve and it not. So the cost of lutetium should be considered here. And I'll be talking about cost at the end for most of the drugs that we'll be talking today, but again, last year the industry-sponsored trial made us believe that lutetium improves survival. Here we see that it probably does not, but the crossover effect should also be considered. I look forward to reading the full paper. And there was also the update of the ENZAMET trial by Dr. Ian Davis, and which confirms the results of the ENZAMET trial that was published 3 years ago. It is very interesting. 3 years ago was the last pre-pandemic in-person ASCO, and ENZAMET trial was presented at the time. And 3 years later, when we are back in-person, we have the updated OS results from the same trial, and the results do not change. Addition of enzalutamide to androgen deprivation therapy does improve survival. And finally, I'd like to talk about the Ewing sarcoma trial that was presented at the plenary, the rEEcur trial. I like this trial for several reasons. One, this is a rare cancer, and a disclosure that I don't treat this cancer, so I don't have the clinical expertise on this cancer. However, I like this trial for several reasons, because this checks all the box for an ideal trial. One, it's a rare cancer, and people always tell you that, oh, because this is a rare cancer, we can never do a randomized trial. That's the most frequent argument I hear, why someone cannot do randomization. Oh, it's a rare cancer, how can you do a randomized trial? This is a rare cancer, they did a randomized trial. They enrolled almost 400 patients in 4 cohorts. So with international collaboration, it can happen. This is an academia-sponsored trial with public funding. Second, the objectives were quite clear. They said we wanted to know among 4 different chemotherapy options that we have, which we should start, which is the best one, which we should give to our patients, A, and B, which should form the control arm for our future trials, because you want to use the best possible treatment as a control arm in your future trials. And third, they started with phase 2 format, looked for the overall response rate, and based on that they took to phase 3 and used event-free survival as the primary endpoint, which is relevant in this case, but they also measured overall survival as the secondary endpoint, and they have data for both EFS as well as OS in recurrent and refractory Ewing sarcoma. They showed that ifosfamide is probably a better chemotherapy compared to the other regimens based on EFS and OS data. But the randomization was quite pragmatic because, it's an international trial. Maybe all 4 treatment options are not available everywhere. All patients may not be fit for everywhere. So as long as there were, the patient was eligible for any 2 options, the patient could be randomized. And that was quite pragmatic approach that I liked. And the other best part of this trial was they report quality of life data. Usually, except for this trial, none of the other plenaries reported quality of life information. This trial reported quality of life information. Again, all the more important because this is a younger population. They reported quality of life information not only for the patients but also for the guardians, for the caregivers, because that also matters. So I can't find any fault with this trial. This is a fantastic trial. I just wanted to congratulate this team. And finally, a comment I would like to make is about the cost of these treatments. Yes, we saw significant benefit with trastuzumab deruxtecan. We had a standing ovation, applause. But what % of patients globally would be able to receive this drug? I would say very few, very few. Only a select group of patients in countries like US, Canada, high-income countries might get it. But the global breast cancer burden is outside of high-income countries. The majority of the breast cancer patients, they are not going to get this drug for almost a decade. These are super expensive drugs. So with that applause, we need to have a commitment about how to reduce financial toxicity, how to reduce the cost of the drugs. What is the point in having a drug that nobody can take? So yes, the results are exciting, but more exciting should be our commitment to ensure that if our results are good, our patients will benefit from it. And how do we do that? And that's the theme of our ASCO as well, equitable access. How do we ensure that there is equitable access? Just getting a new drug is not enough. The same is true for immunotherapy that I talked for rectal cancer. If it pans out, how do we make sure that our patients get it? Circulating tumor DNA. Circulating tumor DNA is a new technology. Patients in low-income countries, they don't have access to it. How do we ensure that they get it? So these are the things that we need to think alongside cheering for these new results and cheering for new innovation. Innovation is cool, innovation is good, but it should be affordable.